بسم الله الرحمن الرحيم. أنا دكتور إبراهيم يحيى علام، أستاذ العيون. النهاردة هكلمكم على الجزء الثاني من محاضرة الeyelid. قبل ما نتكلم على المحاضرة في anatomical considerations لازم نبقى عارفينها. أنا عارف عندكم فكرة عن anatomy of the eyelid. هو في 5 layers starting from the skin ending by the palpebral conjunctiva. We have the skin, subcutaneous tissue, then the orbicularis muscle, then what we call the fibrous layer of the eyelid, composed of the tarsus with the meibomian glands inside, and attached to the tarsus is the levator muscle aponeurosis, then the palpebral conjunctiva. The distance between the skin and the palpebral conjunctiva is called the lid margin. Today we are going to talk about the malposition of this lid margin. As you can see, the anterior lid margin has its lashes like that, and the posterior lid margin has the orifices of the meibomian glands. The meeting of the upper and the lower eyelids called the canthi. We have a lateral canthus and the medial canthus, and the upper eyelid covers 1 to 2 millimeters of the cornea, and the lower lid resting on the lower limbus. The lower eyelid has the same layers, but instead of the levator aponeurosis, we have what we call the lower eyelid retractors. Attachment to the lower tarsus, its expansion of fibrous layer from the inferior rectus and inferior oblique, giving a support to the lower tarsus. This support, if weakened, we're going to have a malposition of the lid margin. These are the malpositions of the eyelids. Today we are going to talk about the lid margin position abnormalities. We have what we call entropion and ectropion. What is the entropion? Here the lid margin is rotated inwards toward the eye, results in lashes rubbing against the conjunctiva and the cornea, which reflects irritation, lacrimation, foreign body sensation, and redness. May cause corneal abrasions with secondary corneal scarring or infections, and it is serious. It may lead to loss of vision, most commonly affecting the lower lids. What are the types of the entropion? May be congenital, spastic, the spasm of the orbicularis muscle, convolutional with age due to laxity of the lower eyelid retractors and the canthal ligaments. This is example of the congenital entropion. The child is born with rolled in lower lid margin with thickened orbicularis muscle, and this is an example of a spastic entropion. This is due to irritation. This patient has a corneal ulcer with severe irritation due to the presence of the ulcer. If the lower eyelid is lax, usually in old population, this continuous irritation and continuous spasm of the orbicularis can lead to rolling in of the lid margin and entropion, and this aggravates the conditions. It's a vicious circle. Irritation by the ulcer, rolling in of the lid margin, more irritation, and so on. This is a common problem in old age. This is another example or another type of the entropion is the senile one. This diagram, the yellow part is the tarsus, and the red one is the lower eyelid retractors, which gives support to the lower edge of tarsus. If it is weakened, the tarsus is rolled in and lid margin rolled in, with resulting rubbing and irritation of the lashes to the ocular surface. This is the fourth type of entropion, which is very important, and it's very common here in Egypt. and I'll tell you why. It's due to shortening of the conjunctival surface of the eyelid, shrinkage of the conjunctiva. So the lid margin starts to roll in. Unlike other cause of entropion, it can occur in both upper and lower eyelids. The other types occurs only in the lower eyelids. The cicatricial one can affect upper and lower one. Why? Maybe trauma, chronic inflammation, chemical burn, and chronic infections. Trachoma is caused by chlamydia trachomatis. It's a chronic recurrent infection starting since childhood. It waxes and wanes activity and resulting in fibrosis and so on. With age, the conjunctiva starts to shrink and the lid margin starts to be rolled in. In the upper lid, it's a problem. We blink around 15 to 20 times per minute. With each blink, the lashes rub against the ocular surface, so it may be a blinding disease. So the trachoma is very important. It's still endemic here in Egypt. And this is the everted upper eyelid. We can see the nice appearance of the vessels. It's healthy vessels, healthy conjunctiva. But in cases of chronic infections, the vessels starts to disappear and replaced by this fibrous scar, and the lid margin starts to be rolled in. Lashes rubbing against the cornea, and the cornea starts to be opaque with keratitis and so on. Not only trachoma, as we said, maybe due to chemical injuries, autoimmune disease of the conjunctiva. All of these results in fibrosis of the palpebral conjunctiva and rolling in of the lid margin. This is important because the patient may lose his vision due to the upper eyelid entropion. Treatment is essentially surgical. We go for surgery, but in case of spastic entropion, we should treat the cause as well. Topical medications to control the ocular surface irritation and inflammation. We give lubricants and topical antibiotics as prophylaxis, but the main treatment is surgical one. The second type of the malpositions of the lid margin is the ectropion. It's rolling out of the lid margin. The lid margin is rolled out. It results in exposure of the palpebral conjunctiva, which becomes dry and irritated. The patients may also have some difficulty closing the eye completely, resulting in dryness of the cornea. The ocular surface starts to be dry. The eyelids cannot effectively push the tears toward the tear drain. You know, the tears are drained from the punctum here. Now the punctum is away from the ocular surface. Our tears moves by capillarity over the lid margin to reach the punctal areas. Once the lid margin is not opposed to the globe, the tears starts to overflow. This symptom called epiphora. Epiphora means overflow of tears in spite of normal secretion. You should differentiate between lacrimation due to irritation. Any one of us can be irritated by allergy, air currents, or whatsoever. We lacrimate. But this is a normal secretion, but there is overflow of tears due to a malposition of the lid margin. It mainly affects the lower eyelids. What are the clinical types? Mainly mechanical. Huge swelling in the conjunctiva can push away the lid margin. Senile, and it's very common due to horizontal laxity of the eyelid. The eyelid is supported by the canthi and the orbicularis. If they are weak due to aging process, the lid margin starts to be rolled out. Another example is the paralytic one due to facial palsy. Cicatricial, unlike the cicatricial entropion, which is due to fibrosis of the conjunctiva, this is due to fibrosis of the skin. Again, it's the only type that can involve both the upper and the lower eyelids. may result from extensive burns, contraction of the skin due to severe eczema, post-operative scar or post-traumatic scars due to lacerated wounds of the eyelids. How to treat is again medication to avoid the ocular surface exposure and prophylactic anti-inflammatories and antibiotics. This is an example of the cicatricial ectropion. The right picture is due to severe chemical burn, and you can see both the upper and the lower eyelids are rolled out. The other slide is due to scarring of the lower eyelid following trauma, and the vertical scars are more serious than the horizontal scars. As you can see, the lid margin is rolled out in the points of traction of the vertical scar of the skin. This is a very common, this is senile ectropion. It's an aging process. Laxity of the canthi and laxity of the orbicularis leads to rolling out of the lid margin, and the patient's main symptom is epiphora, overflow of tears in spite of normal secretion. This is a severe form. As you can see, the fornix is now exposed and the conjunctiva starts to be very dry and keratinized. This is an example of the paralytic ectropion due to facial palsy. If you notice, there is some sort of facial asymmetry because the facial nerve is not working and the facial muscles are paralyzed at this side. There is shifting of the mouth to one side, and all the half of the face is nearly paralyzed. There is an ectropion, very obvious, and the patient complains of dryness and the epiphora. The eyelids cannot close properly due to paralysis of the orbicularis, a condition we call lagophthalmos. We're going to talk about it in a minute. So the patient complains of dryness. At the same time, there is overflow of tears because there is an ectropion, and what's called the pump mechanism of the tears from the lacrimal sac is not working. So the patient has tearing and in addition dryness of the ocular surface. This is another topic is the lagophthalmos. The lagophthalmos is inability for complete closure of the eyelids. Inability for complete closure of the eyelids. The pupillar fissure remaining partially open during blink and during sleep. So the ocular surface is dry and becomes a subject to damage from exposure. What are the etiologies of the lagophthalmos? One of the examples is the facial nerve dysfunction. We call it paralytic lagophthalmos, like the paralytic ectropion. There is weakening of the lid closure, and the facial nerve can be damaged by trauma, like in fractured base of skull, cerebrovascular accidents, and the most common type, you know it, is the Bell's palsy. The Bell's palsy in idiopathic, in most of the cases, it's 75% of case of facial palsy is due to Bell's palsy. Idiopathic, mostly it's temporary, remaining for a few weeks, then resolving gradually. Sometimes tumors can cause facial nerve dysfunction. This is another example of facial palsy. As you can see, the patient cannot close his eyes properly, incomplete closure of the eyelids. Another example of the lagophthalmos or etiology of the lagophthalmos is excessive scar tissue of the eyelids, like cases of trauma. One of the etiologies is physiologic. Many people during sleep, there is incomplete closure during sleep. It's serious if there is no Bell's phenomena. What is Bell's phenomena? Is upward movement of the eyeball during lid closure. Some people physiologically has no Bell's phenomena. It may be pathological, but sometimes it's physiologic, and on lid closure the eye doesn't move upwards. This is serious because during sleep the cornea can be exposed and can lead to serious problems. Another cause of the lack of thalamus is medication effects. During anesthesia, patients in the ICU, especially comatose ones, or patients under sedation or neuromuscular blockade, like during anesthesia. So it's very important to close the eye by strips during general anesthesia or in comatose patient to avoid exposure keratopathy and corneal dryness and may lead to loss of vision, corneal ulceration, infections, and the eye may be lost. So it's very important to close the eye in comatose patients or patients under GA or general anesthesia. How to treat? We do a prophylactic extensive lubrications with artificial tears, preferably preservative free, and long-acting gels, especially during sleep at bedtime, to avoid the dryness of the ocular surface. We treat consequent complications like corneal exposure, keratitis or ulcerations, overnight tapping of the eyelids to close the eye, and what's called tarsorrhaphy. Sometimes we resort to what's called tarsorrhaphy. We close the upper eyelid with the lower eyelids to minimize the exposure of the ocular surface. This in long-term widening of the fissure. Temporary measures is okay if the cause is temporary, but if the cause is permanent, we go to do what's called tarsorrhaphy or surgical suturing of the upper and the lower eyelids. Another topic in the eyelid is what's called an epicanthus. This is a congenital condition. This is a bilateral vertical fold of the skin extending from the upper or lower eyelids toward the medial canthi, hiding the medial canthal tendon behind them. Hence the name epicanthus, or something above the canthus, hiding the canthus. This may result in a false appearance of having convergent squints, or what's called a pseudo-esotropia. You will know it in the lecture of squints or strabismus. The fold may involve the upper, we call it epicanthal folds, fold from the upper eyelid going to the lower eyelid. Sometimes the opposite, a fold of skin extending from the lower one going to the upper one. We call it epicanthus inversus. Treatment is surgical for cosmesis. Another topic you should know is lid swelling. When our eyelids got a swelling, maybe due to allergy like insect bites, angioneuritic edema, eczema, or inflammation of the skin. Sometimes the swelling is due to dependent edema on awakening in cases of congestive heart failure or renal failure or hepatic failure. Sometimes orbital venous congestion like compressive lesions or cavernous sinus thrombosis. Another cause is inflammatory, and this has another signs. There is a cellulitis with signs of inflammations, redness, hotness, swelling, tenderness. The source of infection may be the orbits, like in orbital cellulitis, maybe the eyelids, like inflammatory conditions like STI and inflamed chalazion. Sometimes extension of infection from the lacrimal sac, dacryocystitis, or the lacrimal gland, what we call the dacryoadenitis. One of the inflammatory conditions is thyroid eye disease. You should know that the thyroid eye disease, one of its main manifestations is eyelid swellings. Eyelid malignancies is causing an eyelid swelling, but not like inflammatory or it's a localized swellings. The most common malignancies of the eyelid are the basal cell carcinomas, squamous cell carcinomas, and sebaceous cell carcinomas. They are characterized by ulceration, bleeding, and destruction of the normal anatomy of the eyelids. Example, loss of the lashes, sometimes erosion of the lid margin. or leaving the patient with the dystopia of the canthi or abnormal position of the canthi. The most common is the basal cell carcinoma. It's the most common eyelid malignancy. It is a locally malignant tumor that rarely metastasizes. It's mainly locally malignant. It spreads locally and may cause local destruction and may extend, if left untreated, to the nasal bones, the sinuses, or even behind the globe. The classic site is the nasal part of the lower eyelid close to the medial canthus, but it can occur anywhere around the eyelid, but this is the most common site. It's characterized by beaded or rolled out edges. There is rolling of the edges with necrotic floor and dilated vessels over its margins, what we call a telangiectasia. As we said, it spreads by local invasion of the adjacent tissues and treated by complete excision with safety margin. We leave around 3 millimeters all around, we remove it, okay, and we do a reconstruction procedure. We reconstruct the defect by skin flaps or grafts or whatsoever. One of the malignancies is the squamous cell carcinomas. It occurs more often on the upper eyelid and the lateral canthus. It's characterized by overproduction of keratin, keratotic lesions and scaly surface, giving them a flaky appearance. Sometimes it ulcerates and characterized by everting edges and not rolled in like in the basal cell carcinomas. Mode of spread may spread through perineural infiltration into the orbits or even the cranial cavities if left untreated, lymphatic spread, or hematogenous to the distant organs. In immunocompromised patients, like in leukemic patients or organ transplants or with systemic immunosuppressants, are liable to more aggressive spread of the squamous cell carcinomas. How to treat? Again, it's complete excision with safety margin, and if there is a metastasis or a wide spread of the disease to the body, we go through radiotherapy, chemotherapy, or immunotherapy. Another malignancy in the eyelid is the sebaceous carcinoma. It occurs in elderly population. It's more common in the upper eyelid. It arises from the meibomian glands and glands of Weiss. Those are concerned with the lipid secretion of the eyelids, and it can present as chronic blepharitis, recurrent chalazion, which is important. If you remove a chalazion and there is a recurrence in the same sites, it arises the suspicion for a sebaceous carcinoma or meibomian gland carcinomas. Sometimes it presents with chronic conjunctivitis. It's very highly invasive and very easily metastasizing. So it is a serious type of carcinomas or malignancy of the eyelids. So any old patient with recurrent chalazion must have a biopsy to rule out the presence of sebaceous carcinomas, or all patients with chronic unilateral blepharitis resistant to treatment or conjunctivitis need to be properly evaluated for the presence of this serious type of carcinoma. One of the localized swellings of the eyelid, what we call the xanthelasma. It is a benign condition characterized by the presence of cutaneous lesions in the periocular region. Presents as yellowish white lesion, as you can see here in the upper and sometimes lower eyelids. Taking the medial aspects of the skin of the eyelid, occurs more in middle-aged individuals in the 4th or 5th decade of life. Patients with xanthelasma usually have associated lipid disorder. So any patients presenting with xanthelasma, we should order a lipid profile to the patient, maybe hyperlipidemic or high cholesterol or high triglycerides. However, the patients may be normolipidemic. It's not essentially a hyperlipidemic patient. It may occur in normal population. Treatment, we do a conservative therapy, low-fat diet, and the statins, and surgical excision is the classic treatment of these xanthelasmas. Thank you very much and best of luck. Thank you.